Good afternoon. After that very lovely morning of listening to spectrum of liver diseases, non-neoplastic, which we really enjoyed hearing from Dr. Farrell, and all the neoplastic liver and cholangiocarcinomas, we are going to the afternoon session, which would be more diverse, of course. Now, you become a general pathologist in this session and enjoy each presentation as we do every year. So the first presenter is Dr. Al-Ahmadie. Where is he? Hikmat? Okay. So Hikmat joined us with me 2009. He did his search path fellowship and GU fellowship here. Went away for a few years and came back. He is the go-to person for urothelial carcinoma. He's an associate attending pathologist now, and also he's everything. So he's got R01 funding, looking at the intratumoral heterogeneity in urothelial carcinoma. So you never know what you're going to expect from him. So there you go.
Thank you, Mira, and good afternoon, and welcome back. So naturally, after this introduction, you know I was going to give something related to the urothelial carcinoma. I was generous. I gave 2 cases, but we ran out of space on the DVD, so we ended up giving you 1 slide. But I promise we'll talk about the case 2 that was left without a slide for you. Since the theme is GI, also if there were D today, I'll try to make a link to the GI whenever there is a chance. So there could be something there. So let's focus on case 1. A 56-year-old man was otherwise healthy until he started having some hematuria. Went to the physician's office. They evaluated him with the CT scan. They found some hydronephrosis, multiple bilateral renal cysts. In cystoscopy, there wasn't anything in his bladder, and the ureteral orifices looked normal. They did ureteroscopy, and they placed a stent. The biopsy, they found a tumor in the distal third of the ureter. But then proximal to that, the urinary system looked clean, including the renal pelvis. They biopsied, and then the symptoms improved, and the kidney function also improved with some delay on the affected kidney on the right side. And this is what we have in the biopsy. Is it clear? I think it's a little bright in here. But trust me, this is high-grade urothelial carcinoma. The tumor looked... Can I tell it? Okay, perfect. I didn't even touch it, and it worked. Great. So an overall papillary tumor with hyperchromasia, high NC ratio, a little bit of pleomorphism. We diagnosed it as high-grade urothelial carcinoma, non-invasive. His metastatic workup was negative, and he is otherwise, as I said, pretty healthy, unremarkable previous history. He's a never smoker, so that's one major risk factor for urothelial carcinoma is less likely to be. And I mentioned the link to the GI. He had a colonoscopy about 9 years ago, and it was normal. As part of the standard of care in most of high-grade urothelial carcinomas of the upper tract, he received neoadjuvant chemotherapy, which was followed by a nephroureterectomy, and this is what you all received. In this slide, you have 2 profiles of ureteral section, including this polypoid tumor that is filling nearly the entire lumen of the ureter, and you could imagine how much obstruction there will be upstream from this. Going into a little bit more details about this tumor, you could see that is attached to the ureteral wall with the kind of wide or broad stalk. There's overall inverted growth pattern with hardly any invasion, which when you look at higher magnification, again, you can confirm that anytime you think there is invasion into the underlying stroma, there's basically nothing more than inverted growth pattern of most of the tumor tissue. Going into a little bit more of the histologic features, you can make, within the main mass, you can make some fused papillary structures. As you can see, these fibrovascular cores here. And then a little bit higher magnification, you can see the high NC ratio, even though there is not much of pleomorphism, but these features are diagnostic of a high-grade disease. This would not fall into the low-grade disease. The overall appearance also with the darker nuclei and a little bit basophilic cytoplasm, we use the term of basaloid features as well. So this is a characteristic feature also, or was present in much of this tumor. And even though there wasn't much of a distinct papillary structures within the tumor, as you get closer to the edge of the tumor, you can appreciate some residual papillary configuration of the tumor. Some of the other things that were present was some hyalinization in the papillae, and whether that is related to just a long-standing disease or to the chemotherapy, we don't know. And in some areas, there were some microcysts that are present in some areas of the tumor. So I'm not going to cause any more suspense. We do impact on everything now, so the tumor was sent for impact in this case, and these are the results. There were 40 somatic mutations. This is a high number in urothelial carcinoma. Usually, the average is close to 10, maybe low teens. 40 mutations is a very high number. Another value which is also significant, and if you're dealing with tumors on the Lynch syndrome family, you know that MSI center score of above 10 is the strong correlation with having an MSI high status. This patient tumor was 15.6. And to confirm all these observations, and you know where I'm heading now, this patient was found to have a germline MLH1 mutation and a somatic MLH1 mutation in the tumor. And also, importantly, he had a mutation in FGFR3, specifically this R248C mutation. And as expected, by IHC, markers of MMR protein were negative in MLH1 and BMS2, as you would expect. MSH2 and MSH6 were both retained. So diagnosis, no problem now. We have all the answers that we need. It's a urothelial carcinoma of the ureter associated with Lynch syndrome. But how did we miss all that, and how can we reconcile with this patient's presentation? So we said, let's go into his family history. It wasn't really remarkable much, even though there would be some clues, but in retrospect, everything is perfect. At that time, you couldn't make much of it. His father is alive, 81 years old. He had prostate cancer, confined to the prostate, received brachytherapy, and he's fine now. His mother died at the age of 66 of metastatic urothelial carcinoma of the upper tract. So you may think that his maternal side is perhaps he's carrying the risk from that side. He has a healthy brother and sister. They're doing fine. There are some skin lesions with no other details about them. Maternal grandmother who had colon cancer, maternal grandfather, another history of cancer, but none of them would point to any syndromic association. So as I said, you look at this patient, even with this detailed family history, you can't really call him or suspect a Lynch syndrome based on that. So this basically creates a problem for these patients who will present with no indications or suspicions of a family history, but you find something of great significance, as you could imagine, for him, for his other family members. So what do we know about Lynch syndrome and the association with urothelial carcinoma? Some of the known facts that we're pretty familiar. Urothelial carcinoma is the third most common, following colorectal, number one, and endometrial carcinoma. It prefers to the upper tract, ureters, and renal pelvis. And because of the rarity, first, of the upper tract carcinoma overall, and the syndrome in this setting, we don't have a lot of information. There are some studies reported, but the numbers are still overall limited, and we don't have the full spectrum of what these lesions comprise and what are the genetic makeup of them, for example. So I'm going to show you a couple of recent studies to show what has been done and what is the knowledge that we have now is based on these studies. A study from Cleveland Clinic, they looked at 215 cases as a combination of just consecutive cases and cases with suspicion of, or with history or suspicion of Lynch syndrome. They found MMR protein loss in 7%. Just this is like a number that is important to keep in mind. All of them were, 12 had MSH2, MSH6 loss, indicating an MSH2 lesion, and then 2 only had MSH6 loss. And their suggestion was that if you do MSH6, perhaps is all that you need, and you find it abnormal, you go further, you don't need to do MLH1, for example. And sorry, to go back to this, and there was also stress on the morphology. All these tumors, as they were reported, have inverted growth pattern, no infiltration, and then also high rate of intratumoral lymphocytes. Another study around maybe a year later emphasized on the same morphology, what they call them polypoid or inverted papilloma-like, with hardly any invasion in their reports. They did immunostains in 143 cases, and again found abnormalities in 7 of them, around 5%. But the spectrum was wider here, as they had some cases with MLH1 and BMS2 loss. So then this kind of gives you a sense that there's really no exclusion of any of the known MMR proteins that can happen in the urothelial carcinoma of the upper tract. So we looked at our experience. We've sequenced quite a few urothelial carcinomas. We have now almost like 1,300. These numbers can be updated, but at the time of when we did the analysis, we had more than 1,000 cases, including 170 upper tract urothelial carcinoma. We identified 22 patients that we went further into their tumors. 20 of those had family history suggestive of Lynch syndrome. 20 had MSK impact from tumor normal pairs of their urothelial tumors. 2 patients with confirmed germline MSH2 mutations did not have their tumors sequenced. We're doing this now in a research setting, but had other tumors that were done and found a stronger correlation with Lynch syndrome in terms of the mutation count and the MSI sensor. And 18 of those patients have confirmed germline alterations. And we did immunohistochemistry for all these 4 markers in all cases. So this is the distribution. First, you could see the age, the range from 31 to 86. So no one is young enough and no one is old enough to be excluded or included. So it's just basically open. Anytime you see upper tract disease, chances are there's a possibility of a Lynch syndrome-associated disease. The male to female ratio is similar roughly to the urothelial carcinoma. About 2/3 of the tumor were in the renal pelvis, but about 1/3 were in the distal ureter. And only rare examples were in the bladder, 2 cases. Right and left were equally presented. And the stage distribution was, unlike what has been published, that most of these tumors are basically polypoid and non-invasive, inverted growth pattern. Even though we found that in about 40% of these tumors, as you can imagine, there were almost like 1/3 of the cases that were advanced stage 3 disease. And the morphologic features are also summarized here. All of them had either a papillary or polypoid configuration. So, for example, an association with CIS has not been seen yet in these cases. So all of these tumors are bulky, papillary, exophytic, polypoid tumors. Most of them are high grade with the same exact morphology where there's high NC ratio, basaloid morphology as is shown here. And even though the pushing inverted borders were present in a good number of cases, the infiltrating pattern of growth was present in the other half of these tumors. Again, that has not been reported before. And so these are the other features that are here, and I'm going to share some of these pictures with you. So this is like a classical example of cases that one would see in a Lynch syndrome patients. But as I'm going to show you also, they're not exclusive. So you can see this morphology in tumors that are sporadic. But a good way to start is when you have these tumors with wide bases or even narrow stalks. But the overall configuration is this distinct polypoid morphology. Within the tumor, you can see this inverted growth pattern. But in some areas, you can still see some good papillary formation if you're dealing with a biopsy, for example, or at the edge of the polypoid tumor. And as I mentioned, although all the literature has reported the presence of pushing inverted growth pattern, no infiltration, these are 4 different examples of tumors that have clearly invasive or infiltrating borders. Even though some of them you can see a papillary component on top, but it's clearly invasive here into the periurethral or peripelvic soft tissue, here involving close to the kidney, renal sinus, and here clearly invading the renal parenchyma. So you don't really need pushing borders or inverted growth pattern to suspect a Lynch syndrome patient. Any upper tract disease perhaps should be considered regardless of this, at least this specific feature. Other features that have been consistent is this basaloid morphology. We saw tumor necrosis, and then we saw in some cases, not all of them, increased intra and peritumoral lymphocytic infiltrate. Some other features that have also been rarely, have not been reported, and we rarely see them anyway in urothelial carcinomas. Some of these microcystic changes with myxoid secretions as well. Similar to what was in this index case that I showed you earlier, fused papillary are also common. And some of these hyalinization and microcystic changes we've seen very rarely. And this is, again, a similar case where the patient received chemotherapy. So we don't know if these changes are of any value or if they're just related to the chemotherapy or just like for the presence of a disease for a long time. And as expected, the immunohistochemical studies in these tumors are, as you would predict, in patients with MSH2 germline alterations. You'd have MSH2 and MSH6 loss that was present in 14 of the 22 tumors. Interestingly, germline alterations were found or were able to document them in 10 out of the 14 patients. So there are 4 patients where no real germline alteration was found by the methods that we have. In addition, 8 tumors have somatic MSH2 mutation. Similarly, MSH6 mutations were present in the germline. MSH6 was lost in 4 of the 22 tumors, and all of them had germline alterations. And additional somatic mutations in MSH6 were present in 3 of the 4 tumors. And we had 3 tumors that have MLH1 germline mutations, including this patient that I presented. All 3 of them have MLH1 and BMS2 loss. And only 1 patient, this patient actually had another somatic MLH1 mutation. Now, the genetics of these tumors is also unique. One thing that stands out is the rate of mutation in every individual tumor. As you can see here, this is the tumor mutation burden. It's extremely high compared to your average urothelial carcinoma. And the MSI sensor score is always higher, almost always in all these tumors, way above the 10 value that is really strongly associated with MSI high status. Otherwise, other than the total mutation count, there is a high prevalence of mutations that are common in urothelial carcinoma, but the rate of these mutations is much higher in Lynch syndrome patients, as you can see these two groups compared. One thing I wanted to focus on FGFR3, it's one of the most common mutations in urothelial carcinoma. And in general, there's one single hotspot, which is the S249C in exon 7, which accounts for more than 50% of all mutations in FGFR3. If you look at this cohort, not a single tumor in the Lynch syndrome-associated tumors have FGFR3 249C mutations. In the 16 cases where FGFR3 mutation was present, 14 were S248C. So clearly, there is a strong association of this specific mutation with urothelial carcinomas of Lynch syndrome. The other 2 were mutations in exon 10, 373, and 380. So that seems to be the case, and there was prior reports from our group, also from patients with non-Lynch syndrome, that are not overlapping with this cohort that showed very similar findings. So that seems to be straightforward, clean, everything is nice. So in case you wondered what happened to case 2, so this is what it is, and it actually is the exception. So one of the exceptions. Case 2 is an 81-year-old woman who's been followed for a long time. She had endometrial and colonic adenocarcinomas at the age of 48, and at the age of 73, she was encouraged to go consult with the geneticist, and they did a workup, and she was found to have a somatic germline MSH2 mutation and MSH2 and MSH6 loss in her both colorectal and endometrial tumors. She later developed breast cancer, lobular and ductal in situ. And then in 2018, she had her upper tract urothelial carcinoma. This 2.1 centimeter tumor in the left distal ureter. It's basically a typical high-grade urothelial carcinoma. These are the different morphologic features: papillary but invasive disease, high-grade, a little bit more pleomorphism. When we did impact on this tumor, we found only 17 mutations, which is high, but still not as high as you would expect in MSI high tumors. But the MSI sensor was 0.44, very low value, inconsistent with actually MSI high status. And by IHC, all 4 MMR proteins were retained. So this is clearly a tumor that is developing in a perfect setting for a Lynch syndrome-associated tumor, but it's actually not associated with Lynch syndrome. A tumor has just a sporadic urothelial carcinoma of the distal ureter. But this is not the only scenario. We had another case where a patient who had known history and confirmed germline alteration of with Lynch syndrome, loss of MSH6, who initially developed a high-grade papillary urothelial carcinoma of the bladder, and that retained MMR proteins, and it had 4 mutations only with no high MSI sensor score. Later, like a couple of years later, developed an upper tract tumor that was biopsied, and it was associated with Lynch syndrome. Even though we didn't do impact on it, there was MSH loss by immunohistochemistry. So within the same patient, you had a tumor that is sporadic and a tumor that is associated with the syndrome. So anything is possible. So can we do immunohistochemistry? And can it help us at least in screening? So there was a study that showed, yes, by doing IHC of all 4 markers, in about 7% of the tumors you can find abnormalities. But when they did MSI status, they were able to confirm 4 of the 10 cases. We did a study from here. When we did all 4 markers on 135 tumors, we found higher rate of abnormalities in the upper tract disease, 6 cases out of the 65, and 2 cases of the bladder out of 60. And when we did recently MSK impact, we're still analyzing the results completely, but there were concordant results in the genomics and the IHC in 5 of the 6 cases of the upper urinary tract and 1 of the 2 bladder tumors. One of the upper tract cases, as you can see here, the stains were negative initially. We did the impact. It didn't fit with the Lynch syndrome genotype. We repeated the stains, and I'm showing you pictures of here. They're clearly negative, but so is anything that is normal in the bladder. So probably here a technical issue resulted in negative stain. So this would be a false negative stain and a false positive result, but the genetics did not support it. This is another stain case where IHC can be very helpful. This is a patient with known germline alteration, but the tumor here was heavily infiltrated by immune cells, and you could imagine a next-generation sequencing platform will not give you good results here. In fact, this tumor had actually 2 mutations, but IHC was consistent, showing MLH and MLH1 and BMS2 loss and retention of MSH2 and MSH6. So clearly, this is an exception where IHC could be actually helpful rather than giving you false results. So the last slide is conclusion. We know that now in patients with Lynch syndrome, urothelial carcinoma can develop. It's higher rate in the upper tract compared to the lower tract, but it can happen in both. MSH2 germline alterations are the most common, but MLH1 and MSH6 can be also detected. As one expects, these tumors have high mutation rate, but mutation burden, but also high rate of FGFR3 mutations, especially the R248C mutations. We know that sporadic urothelial carcinomas can also develop in the same setting. And we know morphology is not going, even though it can be suggestive, is not really specific. So maybe there's a case for a routine testing for all upper tract urothelial carcinomas for the possibility of Lynch syndrome. And you can start with IHC if that's all that you have, but also next generation sequencing could be the way to go, or a combination of both depending on the individual situations. With this, thank you. The questions
Okay.
now.
Time for one question, if they have any. So I have a question.
Yes.
So the mutation signature in urothelial carcinoma is also fairly not specific, but you get APOBAC.
Correct. Yeah.
But these, you don't see that in the.
Yes. So clearly, so what Mira is referring to is there is unique association with a unique mutagenic process in the bladder, which is APOBAC, and that's something that can be highlighted by the next generation sequencing. The vast majority of urothelial carcinomas have this signature, and these cases, actually, the ones that were done in the clinical setting, you could tell the signature is actually related to the MSI high signature, not APOBAC signature.
Obviously, the FGFR mutation is more functional studies.
Yes,
in your lab.
and actually there was a recent study showing that the S249C mutation is related to APOBAC, and that's probably why we're not seeing this mutation in these Lynch syndrome patients. But maybe the 248C mutation should be studied further in this setting also.
Thanks.
Yeah.
Okay. Yes?
There are a couple of specific FGFR inhibitor trials that have been
Yeah, I mean, this is great news, but this is very, very new. I don't think whatever was included in the FGFR studies, at least they have not been looked at in terms of the Lynch syndrome association. But there is no reason why these cases not to benefit from the study, because these actually, the drugs, they're not specific for FGFR3, they're FGFR1 and FGFR3.
I know that Lilly has acquired lots of oncology, and they have a couple new FGFRs.
Yes, so from the brochure that they target all the hotspot mutations, like the 249, 248, and the one on exon 10 and 15 as well. So there is no reason why it shouldn't work. But there's an additional thing for these patients, that they can benefit from drugs that have been, that are like pan-cancer drugs that target MSI high status, like immune therapy. So that is another venue that may not necessarily work in all bladder cancer patients, but it seems to be, it should be working on patients with the high mutation burden and the MSI high status.